was thinking how to organize this, and I kind of came up with this version. 3 levels of what you need to know for your exam. And I think it's kind of underestimated, like, you know, really, if you've not taken an exam, like, really, what do I need to know and how do I need to know it? And I'll make clear what that means. So number 1, you need to know the range of exam topics you're tested on. Now, this might seem kind of simple, but there's a little bit more to it than that. And this will be the longest section, the number 1. Number 2, you need to know the features and properties of each disorder, each treatment, but also their relationships. Like, what are the differences and the similarities between one thing and another? What's the difference between somatic symptom disorder and illness anxiety disorder? What's the difference between anorexia and bulimia? Now, you might think you know that, and maybe you do, but maybe it's not as clear in your mind as you may think. So if you learn the criteria cold for disorder A and then disorder B, and you get like a clinical vignette, it still might be kind of hard for you to figure out what the right answer is, because you didn't give yourself the opportunity to say, what is actually the biggest difference between disorder A and disorder B? So when you're learning disorder A and disorder B, you have to learn 3 things. You have to learn what are the criteria for disorder A, you have to learn the criteria for disorder B, and you have to learn what are the differences and similarities between those 2 things. As you're studying them, you need to be comparing. Study always has to be very active. It's not just kind of letting the information somehow, or my voice or whoever's voice, like wash over you. And then number 3 is, well, what is the way you're being tested? Okay, so now you learn the criteria for disorder A and B and the differences, but how is the ABPN going to test you on those criteria? Are they going to say, which of the following is not a criterion of major depressive disorder? No, they're not going to test you that way. So you have to know how your knowledge will need to be deployed in order to answer the questions that the ABPN presents to you. So let's start with level 1. What is the range of the exam content you're tested on? So let's start with the basics. This is the psychiatry certification exam. And this is dimension 1. And I have 3 colors here, green, yellow, and red. So green, these are the big topics, right? So if you're going to be short on time, and believe me, there will become a time where you're like, oh my God, I'm not going to get through everything. It happens to everyone. No matter what your plans are, you're going to feel like, I just wish I had 2 more weeks. So what do? You do the Doc Sutton. You follow the Doc Sutton rule. Doc Sutton was a bank robber, right? You know the story. He was asked, Doc, why do you rob banks? He said, that's where the money is. So why do you study the big topics? That's where the questions are. You know, sometimes you're just going to have to drop off, you know what, sleep disorders, I just got to get that, I got to let that go. Because I got bigger topics to focus on that don't have 4 or 5 questions, but maybe have 35 questions related to that topic. So you need to know what the big topics are. The yellow is like the medium-sized topics. They kind of come next. And then the red one is that I've saved that for neurology. Because this kind of drives me crazy, the neurology thing. Back in the day, the psychiatry certification exam had like 35% neurology. Then it went down to 25%. Now it's 5%. And now I don't know what to do with it in a way if I were taking the exam. Because it's like neurology, it's a whole field, just like psychiatry. So like, almost like, what am I supposed to do with it? So this is why we have Dr. McCoy giving kind of like a tour of neurology during this course. So I would say don't ignore it. 5% is meaningful, but you're not going to learn a whole nother field for 5% of the questions. When you got your own field of psychiatry, that's 95% of the questions. Now, for each topic, like, mood disorders or, psychotic disorders, what about them are you tested on? And this is dimension 2. And here are the 3 big kind of components of each disorder: neuroscience and mechanisms of disease, clinical aspects of psychiatric and neuropsychiatric disorders, and then treatment. What parts of treatment? Somatic treatments, which include obviously medication, a ton of questions on medications, but also neuromodulation treatments, or sometimes called somatic treatments, like TMS, ECT. And then, of course, the whole range of psychosocial treatments you'll be tested on. And then you have to know kind of the treatment algorithms, like what's first line, what's second line. Is psychotherapy first line and then med second, or vice versa? Or they differ by the severity of the disease? So you have to know about each treatment modality, and then where kind of more or less where it fits in the treatment algorithm. Now, this is for the continuous certification exam. So I'm showing you. You could go back to these and review them. You could find these documents on ABPN. If you can't find them, just email me, and Diane or I will send you these PDFs. These are ABPN documents. Okay, so this slide is the one. I wanted to get everything the way I think about and learn myself about each disorder. This captures like every aspect of it. It's overwhelming. And you might think like I'm completely nuts. Listen to me, to my explanation. If you still think I'm nuts, then just ignore it. It's, whatever. It's optional. You don't have to think about it this way. Or you might think like, oh, I like the thing about organizing myself, but I want to do it. This Dr. Jack's way just doesn't work for me. All right? So I'm going to break this down into like piece by piece during this lecture. But let's just look at the big picture. So we have this box here, and on top it says past, current, now, and then the future. And then right in the center, that's the disorder. So let's say I'm studying, I don't know, how about binge eating disorder, right? That's the thing I'm studying right now. And that's right in the middle there, disorder, diagnostic criteria, right? And so I'm thinking about the patient. Well, like the patient comes to me and has symptoms of this disorder that I'm now learning about. But where did this disorder come from? So that's the past, right? So you look at the left side, that's the past. Like what led to it? What are the mechanisms of disease? What causes binge eating disorder? What are the etiologies, the contributors? The causes, contributing causes, right? What's the pathophysiology? Are there genetic components to this? Environmental components? Interaction between the two? Is it based on childhood events or now during adulthood events? What are the risk factors? Right? They're not causes, but they increase your susceptibility to developing this disorder. I need to know what those risk factors are. I need to know what the protective factors are. And then also, because the ABPN tests me, I need to know what the normal physiology or normal, neuroscience, the neurophysiology or neuroanatomy is like. There's not that much of that in there, but it certainly does come up. Now, if you're kind of thinking like, oh my God, this is so much, we cover this in all our lectures, right? But as you're kind of processing this, it's good for you to know this too. So that's the past. Then we have the current now. So also when I'm learning about binge eating disorder, I need to know what is it comorbid with? And what's in the differential? And then also, just as I need to know risk factors for what may contribute to a binge eating disorder, binge eating disorder is also a risk factor for further things. We call those sequelae. Right? One bad thing leads to other bad things. So what are the potential future sequelae, right? That's the future. You see there, that's on the right. And then below that, we have the assessment, and those are the yellow arrows, and there's 3 of them. That means when I assess things, I'm not just assessing for someone's symptoms right now. I need to be assessing things and their protective factors, their risk factors, things like that. I need to also be aware, like, in what ways can I prevent any kind of sequelae from developing? That's called tertiary prevention. And then, of course, the treatment. Biopsychosocial treatment, but also then biopsychosocial treatment acutely, and then biopsychosocial treatment long-term. One of the things, when I used to work a lot with the residents, they had too much of like a present-focused view. And it's like almost every psychiatric disorder is chronic. Could be chronically continuous or chronically recurrent. It's never going away. Even if you once attempted suicide, you are now always going to be at much higher risk of future suicide attempts and perhaps death through suicide, right? So all of those things on that slide I just put into normal, like, text here, because this may be more kind of conducive to your way of thinking about it. Okay? So again, mechanisms of disease, pathophysiology, risk factors, protective factors, neuroscience, normal psychophysiology. Mechanisms of disease, etiology, causes, pathophysiology, mechanisms of disease, risk and protective factors, normal anatomy and physiology. Biological factors include genetics. It includes in utero exposure, life exposures like to lead, right? Temperamental aspects. A lot of the anxiety disorders, or all of them, and some of the mood disorders, are related to people who have like behavioral inhibition. It's a temperamental trait. There are these psychosocial factors I have to be thinking about. And then these dynamic cascading and pathway effects. Okay, what does that mean? Well, let's say you've got depression, and you have a little bit of depression. And because you have a little bit of anhedonia, and you're feeling kind of ugly, and you don't really want to be around people because you don't feel like you're boring, and you're just, and you're not really getting that much enjoyment out of it, and you start isolating. So now isolation leads to lack of anything good. You're no longer meeting with your friends. Maybe you're not meeting with your kids, your grandkids, whatever you're not, I don't know, you gave up gardening. So now all of a sudden you're you're losing all of the rewarding, life affirming things that you used to do. And then that deepens your depression. And then also a lot of people, and this is kind of like blaming the victim, but not really. We all have, every human being has a very common coping strategy, which is often, not always, often very counterproductive, maladaptive. And that is escape avoidance, right? The one thing you fall off the horse, you want to get back on it. But what you often do is like, well, I'm not getting back on that horse. I was a little socially awkward, and I had like this bad event, so now I'm going to avoid social interactions, which just then deepens the problem. Now, let's look at the middle one and go into more detail. I have these kind of moon shapes around the big disorder circle, which is our kind of like the main focus of what we, this is my study organizational tool. The ones on the left are kind of like the previous episodes. Is this the first depression that the patient's having at the age of 65? Or is it that 10th one, and their first one was when they were 15? So I want to know the history of previous of this disorder, and then I want to anticipate what the future can hold. right? If the patient had had a medically serious suicide attempt, like, I really want to know a lot about what led up to that suicide attempt so I can intervene and prevent future ones or minimize their occurrence. In effect, I'm trying to change their future trajectory. I'm a change agent. I change the future, right? And then the differential diagnosis, these are the ORs. It's either binge eating disorder or it's something else, like anorexia or bulimia or something, right? But also there are comorbidities, because almost every psychiatric disorder has a whole range of comorbidities. And then a lot of the disorders could be either comorbidities or in the differential. They could be either like ands or they could be the ors. Okay? So what do I need to know about binge eating disorder, about the disorder itself? The diagnostic criteria, associated features, variants, demographics, special populations, prior history, future history, like I said. What can I predict from the past and current episodes to predict the future? And then I'm also interested in again, the future episodes of the index disorder, but also of additional sequelae. So people who have eating disorders are likely to get depressed. They're more likely to develop substance use disorders, even if they don't have them right now. So you see, I'm taking also like a chronological point of view. Like, here's binge eating disorder. What the heck led up to it? And what bad things can occur from it going forward? So this is, I'm not going to go through this because it's just like kind of going into more detail of what I've already said. It's really kind of thinking things through. And now you're going to also be already thinking, well, how am I going to be tested on this? Well, a lot of the questions on the ABPN exams are judgment calls. They're going to be the clinical vignettes that require a judgment. It'll present a vignette, maybe say, well, what's your next step? What's your disposition? Does this patient need to be hospitalized or not hospitalized? And these are very frustrating questions to people because there are fact-based questions, like something very clear, like which of the following medications is used to treat treatment-resistant Tourette's disorder? Blah, 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 Pimozide. Oh, it's Pimozide. Okay, it's kind of fact-based. It's like, I'm not going to use my judgment. It's like, it's in the guidelines, criteria, whatever. But a lot of them are judgment calls, especially those extended vignette questions that are on the exam. So you have to become also comfortable dealing with uncertainty, because it's sort of, you know, the question might give you a vignette and then it says, you know, what would be your next step? Or which of the following three things would you do? If it's extended vignette, right, it's more than one right answer. And you're like, you read them and you're like, I would do all 5 of these. Why is it telling me I can only do 3? Or 2 or 1, whatever it tells you to answer, however many it tells you to choose. And you have to use your judgment. Certain things take priority over other things. And it's a judgment call. And you just have to get used to that. And what you have to do is don't try to outsmart the question writer. Instead, use your own clinical judgment. You've all seen hundreds, if not thousands, of patients. Trust your clinical judgment. Pretend that this case is a case you're seeing in your clinic, your ER, your inpatient unit, whatever. Now, why these red arrows? Well, again, they're kind of like, you know, if you start getting some depressive symptoms, they can circle back and lead to increasing. It's like a downward spiral. People spiral into things like depression or social anxiety or whatever, right? And also they lead to greater risk for future other kind of psychiatric disorders. All right. Now let's look at we're looking now at prognosis. How do you decide on a patient's prognosis? Well, kind of looking at everything. How bad, how bad are their genetics, quote unquote? How bad are their genetics? How serious is the disorder? How long-standing has it been? How resistant to treatment has it been? What other bad things has it led up to? So also kind of the burden of disease. There are all these comorbidities. And then also, like, what about the, maybe barriers to care, lack of supports? So all of those things will feed into prognosis. It's not just one thing. It's all of those kind of things I mentioned. All right. Now we're looking at assessment. So I for years now, I've kind of think, okay, like assessment. What are the categories of assessment? And I think about like five categories, just to kind of keep myself organized, right? Number one are taking a history, right? So that's from, patient interviews, collateral informants. It could include rating instruments. It's all interaction and talking and observing the patient. Number two, it's a physical exam. And vignettes will often include stigmata or ask you to look for things like stigmata of genetic disorders like trisomy 21, perhaps, or stigmata of abuse, bruising, signs of neglect, signs of malnutrition, signs of, fetal alcohol syndrome, things like that. So physical exam, neurological exam, that may be included in vignettes, or you might be asked what's needed to be done. Three are all the lab things. Usually venous lab, but it could be arterial lab for blood gases, obviously CSF, urine, things like that, lab tests. Number four is going to be like all the imaging stuff. X-rays, CAT scans, MRIs, ultrasounds, EKGs, echocardiograms, all of that kind of stuff. And five is everything else. What is everything else? Well, occupational assessments, vocational, academic, neuropsychological testing. So those would be in that category. Now, when you're considering whether, which lab tests you may need for a patient, never kind of think about them as being routine. Think of them as being vital for you to establish a diagnosis and or a treatment plan. So why would this lab be more important than this other lab? Well, because they can help you differentiate one disorder from another disorder. Or it could help you, obviously, medical conditions that could be leading to the anxiety or to the depression or whatever, right? You're going to get a TSH and other things like that. So yeah, just kind of think about which take priority and why are you getting those? Why are you getting, the patient with dementia, why are you getting a CBC? Again, these are the kind of things that could be, you're thinking them through as you're studying. So you understand exactly what you need to do and why you need to do it and what takes priority. And then treatment. There's acute treatment, and then there's, especially for mood disorders, continuation treatment, which is part of treating that current episode. Obviously, I'll go into a lot of detail on this when I talk about depression. And then maintenance treatment. Maintenance treatment is preventative. It's trying to prevent future episodes. It's no longer treating the current episode of illness, but trying to prevent future episodes of illness. And then biopsychosocial, right? Or you can just, if you want, just divide them into two categories. The biological ones, meds and neuromodulation, and then the psychosocial ones. And again, here they are, you know, just to kind of list them out. Psychological treatments. If you're going to focus on any of the psychotherapies, CBT, please understand the major, it's not hard, but make sure you understand the basic concepts of cognitive and behavioral therapy. And we usually just say CBT as if it's one thing. But, you know, in the past they weren't. There was cognitive therapy and there was behavioral therapy. And in fact, the cognitive psychologists and the behaviorists hated each other. It took decades for them to actually like merge because they found it works better together. So what is cognitive therapy? And then what is behavioral therapy? Well, there are a lot of different kind of behavioral therapies. There's exposure therapy, there's behavioral modification, to name two major categories. Well, what next? Well, some smaller ones, but that are, you know, kind of have clear evidence of being useful, like for depression, problem-solving therapy. There's always a little bit about psychodynamic therapy. And then out of like those kind of like programmatic, very comprehensive therapies, I think DBT would be at the top of the list. And then know things about like day programs, partial hospitals, assertive community treatment, and rehabilitative programs. And then social assessment and interventions. Basically identify any of the protective factors and beef them up, identify risk factors and try to minimize those. And then recognize psychiatric emergencies. So make sure you know things like what serotonin syndrome looks like, neuroleptic malignant syndrome, and all of these other kind of things. Okay? Now level 2. So one of the problems when people study is familiarity is not knowledge. So you may have listened to, or you might listen to my or other speakers' lectures once, twice, 3 times, and you're driving and listening. I mean, it's kind of funny, you know, people sometimes at the APA, they come up to me and they bring their like kid and say, hey, that's Dr. Jack. They say, you know, because I was listening so much to your lectures when I was driving my kid around, you know, there. I'm like, oh, well, you know, nice to meet you, you know. But just listening to me or anyone else, and I don't care how brilliant or not brilliant the lectures are, you have to engage with it. And what the issue becomes, the problem becomes, is that just listening to that person speaking, or if you're reading those words, and you're like, I'm really familiar with this. But that doesn't necessarily mean you know you've developed understanding of it and that you could deploy it. So you have to be very careful about that. So you have to basically engage with that information, and I'll show you how as we go through this. So first, let me show you example 1, major neurocognitive disorder, general diagnostic criteria. So let's say you're reading this, and you're kind of like, okay, I got it. Okay, I read it. You know, I read this 3 times. I think I'm ready to move on. And now you read the mild neurocognitive disorder criteria, and you're kind of like, okay, yeah, okay, I read this 5 times. I think I'm ready to go, right? But what you need to then do is to do this. Like, hold on a second. How does this actually differ from this? And by the way, why is it major and then mild? It's not major and minor, it's major and mild. And then major also has severity criteria. So you can have major neurocognitive disorder, mild severity, which is different than mild neurocognitive disorder. What? So then you have to like do this, right? Again, you have to know A, you have to know B, and then you have to know what makes them different. But if you just read these, I'm telling you, this is a great example because it's very simple. You might think like you know this until time comes to answer a question. You're like, I never thought about how they'd really differ. I mean, I was just reading the words over and over. I mean, I'm not saying you're doing this. So again, learn topic A, all of its components, learn topic B, and then number 3, learn what distinguishes A from B. Another example is, okay, there are all of these neurocognitive disorders I'm reading about. There's Alzheimer's, vascular, Lewy body, frontotemporal, blah, blah, blah. But, you know, then you have to kind of, again, well, how do they compare? What's going on here? So you can classify them by etiology. Neurodegenerative diseases, yeah. Oh, but traumatic. Oh, you can have NCD that's due to a one-time event. It's not just Alzheimer's disease and Lewy body disease and cerebrovascular disease. It could be a motor vehicle accident and me going through the windshield. That's why, by the way, the ABPN changed it from dementia to neurocognitive disorder, because you can be a child and have neurocognitive disorder because maybe someone dropped you on your head. That would be a neurocognitive disorder. That's not Alzheimer's disease. That's traumatic brain injury. So you see how you gotta you're constantly thinking. So it's okay to listen to lectures while you're driving, because there's a part of there's a way that can help. Especially if you're already kind of familiar with the material and you're kind of thinking it through and reminding yourself. But if that's all you do, you're probably not paying enough attention. And then there's all these other ways of categorizing. So here's another example. Example 3, early versus late onset Alzheimer's disease. So right away, I'm comparing early onset from late onset. How do they differ? And then in early onset, there seems to be 2 different versions of that. The half of the people with early onset Alzheimer's disease have early onset familial disease, while the other half have the sporadic Alzheimer's disease like you would see in the late onset group. The sporadic disease, does that mean it's not? Okay, the familial one, obviously that has a strong genetic basis, but does that mean the sporadic one doesn't have any kind of genetic component? No, it does not mean that. So sporadic Alzheimer's disease, right, there are multiple risk genes, multiple genes or versions of genes, alleles, that contribute to the neuropathological changes, right? Like the main genetic risk is apolipoprotein E epsilon 4 allele. It's not a causative gene, or not a causative allele or variant of that gene, but it's a risk factor. It increases your risk by several times. And then you read about well, what about these causal genes that actually cause, right? They have autosomal dominant inheritance patterns. There are 3 of them, right? You've heard this before, presenilin 1, presenilin 2, and then amyloid precursor protein, and you're kind of okay, I'm trying to just memorize this. But instead of just memorizing it, let's slow down and say, well, hold on a second. What are these all 3 genetic or mutated genes? Doesn't mean there's 3 genetic mutations. There could be more, but there are 3 genes that are affected by these missense mutations. They all have a final common pathway. They produce increased levels of the ratios of amyloid beta 42 over other forms of amyloid beta. And amyloid beta 42 is the main neurotoxic peptide, and it's very sticky and it forms these senile plaques. So the presenilin 1 and presenilin 2 are proteases that cut amyloid precursor protein in a spot that produces more amyloid beta 42. So you can have bad scissors, bad proteases, or you can have a bad amyloid precursor protein. So with good proteases, they still end up cutting the bad amyloid precursor protein and you still end up with more or higher ratio of amyloid beta 42. So you're now oh wow, now I get it. Now I get it. Right, I'm rushing through this. I'll explain this. These are actually slides from my neurocognitive lecture. Right? And level 3, knowing the way you'll be tested. Okay, here's an example. Major neurocognitive disorder with Lewy bodies, diagnosis. Criteria are met for major NCD. There's insidious onset and gradual progression, and there's presence of core and suggestive symptoms. And these are the core and the suggestive features or symptoms. Right? The core ones are fluctuating cognition, recurrent detailed visual hallucinations, Parkinson motor symptoms starting fewer than 12 months prior to cognitive decline or following cognitive decline, suggestive diagnostic features, REM behavior disorder, severe neuroleptic sensitivity. Okay, you learn this, and you actually take time to kind of think it through. Okay, you got it. And then you're still like, well, how am I going to be tested on this? This is how you're going to be tested on it with a vignette. An 80-year-old woman has fluctuating levels of attention and cognition. All causes of delirium have been assessed for and excluded. What's her most likely NCD type? Right? NCD with Lewy bodies. A 72-year-old male patient with cognitive impairment develops frightening visual hallucinations. You prescribe low-dose risperidone. The patient develops severe bradykinesia, tremor, rigidity, and gait disturbance. So what happens? He's got both visual hallucinations, that's one feature, and the other one is he's got neuroleptic sensitivity, and he develops what? Number 3, Parkinsonian motor symptoms. So he's got NCD with Lewy bodies. So that's how you... So this is when you're studying something. Let's say you're studying like a disorder you don't treat. You're a child adolescent psychiatrist, you don't treat older people with dementia. Or maybe you're a geriatrician, you don't treat people with ADHD or with autism, whatever. Write your own like vignette, or think about a patient that would remind you of that. You hang all of those symptoms on a person and kind of like, okay, now I understand. Kind of make them like personalize them. Here's another example. This is the simplest example I could give. We all know the major depressive episode criteria. There are 9 of them, and there they are, right? Now, one thing that I kind of realized at some point is that fall into 2 categories. They're the neurovegetative symptoms, and they're the depressive symptoms that are kind of depressive emotions, cognitions, and behaviors. And out of the 9, 5 are actually neurovegetative symptoms. So we know we need 5, but we also know that one of them must be number 1 or 2 below depressive ones. Depressed mood or anhedonia, diminished interest or pleasure. Right? So emotional symptoms, I need 1 or 2. Because otherwise, if it was just 5 symptoms, they could be all neurovegetative symptoms, and I could have those neurovegetative symptoms with diabetes mellitus and now with depression. Now also, let me make note to myself that depressed mood is most of the day, nearly every day. What if it's not? Well, then maybe it's not a major depressive episode. Now, what does depressed mood mean? It doesn't say sad mood, it means depressed mood. What is a depressed mood? Well, it's really any kind of dysphoric mood. Some people, they don't really feel that sad. They feel a sense of doom and dread. They feel like they could die at any moment, like something bad is going to happen. Like everything is on the verge of just falling apart. They're kind of sad about it, but they're more dreading it. And again, 5 out of the 9, a majority of them, are things you can just get from a medical condition. Another example. Okay, what's the difference between bereavement and a major depressive episode? Again, you might know one, you might know the other, but you got to know what the differences and similarities are. Right? Again, learn topic A, topic B, and then the number 3, learn the difference between them.